if I can take permission from the next speaker, Dr. Shekaran.
I've been just put in here in between. I bring greetings from Mangalore, Kasturba Medical College. I do not have any conflicts of interest to declare. And I was asked to speak on the management of postpartum hemorrhage, especially the newer modalities of it. That is, what is new in the management of postpartum hemorrhage. That made me keep thinking about it. Is there anything new in the management of postpartum hemorrhage? Just looked into what is new. That is newer. When you talk about it, there are a variety of meanings that are given. Initially, I thought new means it is one that is new, that has come up of late, and then we are not aware of it. But again, the different meanings that it gives in the dictionary, that makes that, to summarize, it is very subjective one, and probably what is new is that what we do not know, or maybe that we do not have it with us because it is already known, or is it that it is there but we haven't used it. Any of these would come under the newer modalities. So with that, what I will be talking about is only that what you have gone through in the last 2 days, and maybe in the morning today, it would be summarized to some extent. I would be rushing it through. Because you all know that whenever there is a postpartum hemorrhage, mind you, I am not talking about the prevention of it, it is the management of a patient who had already developed a postpartum hemorrhage. Recognition, I don't think there should be anything new for it. And then as far as it comes into reporting and then reassuring, and then the recording whatever that happens, and then the counseling, the people who are working with you, and then the patient when patient's attendants. So it is important. And then it must have been, again, honed it in, and then it was mentioned that we need to have a structured and communication for its effectiveness. The SABR is being used, especially in the NHS, probably it can be utilized. I need not go into, probably it might have been talked about in the workshop. And then resuscitation, is there anything new? Probably they are, but they have already been talked about. The fluid management and others must have been already talked about. The identifying the person who requires resuscitation is already known. I thought it is not required. I just put in a tick mark. And then about the reassessing the patient once she is under treatment, to re-evaluate it. And re-evaluate it, again, it has been there, and then it would be whenever Dr. Arul Kumaran is there, he would be talking about it. And then how do we, I wanted to go through Muse. So you know that wherever, if there are 2 ambers or 1 red, you try to think about it. And then, for example, it is not that you have taken care of from ICU, she has come to HDU, then she will not go into the problem. Then is, of course, the treatment. So now my problem, I'm getting into the treatment mode. So in that, again, I have gone into the R's in that everywhere, right from the beginning. One is restoring what is lost. They have talked about the fluid and the blood product management that you have been aware of. Retoning the uterus. That is anything that is there anything? That's the question that I wanted to ask. Is there anything beyond oxytocin and prostaglandins that is available? And then that too, when it has been told time and again, and then it has been circulated in the WhatsApp messages that oxytocin is falling short of, then do we have anything new? So with that, is there the answer? The carbetocin, probably that it has been said again earlier, Bella was telling that only it has been said that it is not inferior to the one that we have been used to, right? It has been only for the prophylactic management that it was used, and then the varieties of its pluses about the carbetocin, you know that is very long acting, and then it is about nearly 10 times more potent and an active than that, and lasts for than the oxytocin. And then how it is to be given 2 dose, that's only single injection to be given, 90 to 100 micrograms. And then the only thing that cost per wise, since you are giving only 1 injection, probably it is not that high. And then the fluid that is used is not going to be much. So this is the cost as of now. Probably once the government says that only carbetocin you use, probably it would be given it. What one needs to be worried about is its effect on the blood pressure, and then that needs to be re-evaluated and then attended to. So I think it is too smudged. What I wanted to tell about this is the one thing that they have given, I thought it is a very harsh statement that it should be actively discouraged for use, because whatever the evidence that we have is for the non-inferiority level of it for the preventive aspect. For the treatment of the postpartum hemorrhage, probably, I think what they have written there, we need to be taken into, and then I have put in a red mark there. And then coming to restricting the blood loss. Again, the third R I'm talking about in the management of postpartum hemorrhage. In that we know that variety of this, compressing the uterus, ligating the vessels, clamping the vessels, embolizing the vessels, and then blocking the area from where she is bleeding. These are the few aspects that we have tried to address to over the years, time and again. Right, coming about the compressing, we have all been through it. We will be using different combinations and permutations of the compressing the uterus. And then even compressing in a sustained manner, we have developed different braces. B-Lynch came, somebody modified it. Then came the chores, and then the varieties of modifications, single one or multiple braces. So many things have come. Then probably all said and done, it would be maybe able to address to or avoid hysterectomy in about 80 to 90% of the cases. So in that, this I thought I would bring in. So what it has been said, though you have put in a brace, while we're waiting for it, so can we embrace it? In that, squeeze the uterus over it. What has been done, external uterine tamponade, in that, at the laparotomy, wrap the uterus with the elastic bandage, keep it over 45 minutes, remove it, wait, and then close. So this is one of the articles that had come where they had tried it on 10 patients and then none of them had had. It is too small a one to say that it can be the policy. So again, why not give a try in case if it is not helping, the squeezing the uterus at laparotomy. And ligating, so you know that the uterine artery, the utero-ovarian anastomosis, or the internal iliac ligation, we all know of it, and then one has tried to use it sequentially or a stepwise approach, or selectively only one of them. And then this again helps to say again about 80 to 90%. So we know that the uterine artery can be ligated, and that is the first step that you do whenever you know that that person is likely to have a postpartum hemorrhage. Let's say it is a over-distended uterus or one is doing a cesarean for a placenta previa. We might as well make it as an elective step to ligate the uterines. So when you are doing and when you come across a postpartum hemorrhage, can we make a revisit to occur? This was not a quite new one. It was 1997 this article had come, and then some of us have used it, that is ligating the uterine artery in the labor room itself before shifting her to the OT for the stepwise ligation. So I will not go into the steps of it. It can be achieved because there is cleavage is easy, tissue is edematous, make an incision in the utrovesical fold, push the bladder up, and then apply the ligatures and close the wound. So probably one local anesthesia is sufficient, and then one would be able to do it. Can you make it to revisit? Because I don't think every one of us are doing it. I had done it some time back, but I have not used it routinely. So probably it is if you are placed in a place remote from the place where you can undertake the rest of the procedures, can we do it and avoid the laparotomy in her? So in that, when you are talking about the revisits, then there are the renovations or innovations that have come in, and the person has patented this kind of a clamp wherein one portion goes into the straight, one goes into the through the cervix into the uterus, and the rest one will go to the laterally, compresses the uterine artery, right? So then maybe around the same time, I think it is like the camel shred that goes in one camel after another in the such articles have come in crops. Around the same time, another instrument was devised wherein two things are there with the central this thing. So different instruments are designed for the same purpose. Principle is the same, compress the uterine artery. That is clamping the uterine artery vaginally. And then our man is now behind, and then these are also devised in Kerala, Dr. V.P. Paili. The uterine clamps, 2 of them you require, you just place them there. Then again, from Karnataka, this Ramlingappa, he had talked about in the last Kasoga oration, Kasoga conference, that wherein he tried to say that we don't require any special instrument for it. What you need is only 2 speculum, 2 sponge holders to hold the cervix, and then 2 the uterine artery clamps. That is the straight clamps that you use for hysterectomy. Maybe you can insulate them, put them on either side of the cervix. So he said in the 300 odd cases that he had studied in about 5 years' time, there were only 7 cases, that is 2%, that required hysterectomy. Probably the innovations of clamping the uterine artery in the labor room might save or avoid laparotomy, right? So this I quoted it because I cited it because it is because of the simplicity, and then probably it is effective. Maybe 2 more minutes I will take. The uterine artery embolization, I will not talk about it. Again, around 90% success in that, we will be avoiding hysterectomy there. And then coming to the uterine, the cavity itself, can we have this also you are all known of, there are different ballooning or a tamponing has been done to block the uterine cavity itself. And then whenever I meet Dr. Shekaran, he gives me some, the tamponades, I carry them. There are a variety of modifications to it. So I'll not go into the different details of it. Everyone is aware of it, and then everyone is using them. Then what I wanted to bring in out, again, it comes from, again, there are a variety of authors that have come forward with this. Whoever is the owner of it, the thing is, sucking the uterus, can it help in trying to avoid it? So in that, again, the different instruments. One has used it at cesarean. You are sucked out because 1 or 2 membrane pieces, if they are there, you try to suck it out, uterus gets stimulated, and then the bleeding stops, and then what you have removed, what you did not want to, leave it behind. So the only thing is concerns would remain, will it not avulse the endometrium or the basal decidua, or will it, while you're trying to pull it out after the complete suction and over a period of hours, will you not damage the cervix? Probably authors might say it is not. There are a variety of all of them had come around the same time. These articles have come. Maybe one can give a try to it. And then about the sticking, I brought it. Last one, it is that placental side that is bleeding. So in that event, can we use this? Is the hemostatic agents, can they be used locally? So this is the one that is collagen sponge. It has been said that it is helpful, and on when it is applied, you apply it over 3 to 5 minutes, and then maybe you can apply it again to the posterior wall or whole of the uterine cavity when covered with that, and press it over for 3 to 5 minutes. It would reduce the bleeding. So again, there are comparative studies, even an RCT has been reported about it. So each one of the sponges, this Tacocil costs about 26 to 30,000 per piece. You would require at least 2 of them. Is worth. And then what I have used is this one that is available in our OTs, the Surgicel. So that also to some extent it does help. It works on the same principle. And then you have these hemostatic agents like fibrin seals. Can they be used? So especially these can be used. There have been reports of using these fibroseals for vaginal, that man-handled or the woman-handled vagina that come with. It was being told that how do you repair vaginal tears? When you apply it, you reapply, it continues to bleed. Then why not use the sealant there and then compress it? Probably it might help, and it has been reported. If it can be helped there, why not be put it in the uterine cavity if the uterus is atonic, and then maybe at the time of cesarean, why can you apply it and then see? So there's only a thought that I have put in 2 questions there. So this is the sealant Tisel. So it costs about 9 to 10,000 rupees, worth it. And then of course in this era where the accreta is going hand in hand with the rise in cesarean rates, probably it is not exactly for the management. I just wanted to remember those 3 Ps whenever you are dealing with patient with accreta syndrome, wherein so the Dr. Shekharan will, he will keep on telling again and again, perioperative placental localization is very important in such cases. And then the pelvic devascularization to be taken care, to be undertaken. And then, of course, the placental non-separation is the one that has been recommended there. And then to go in for myometrial excision, they should work in only in creta. Probably when it has gone per creta, and it has invaded into the bladder, probably will not be able to do it. So another one, last one, is about the use of recombinant activated factor VIII. So this has been used everywhere and then can be used, right, is that. And then the blood loss will reduce by about 85%, and then maybe about 2 injections are required to be given at 5 minutes and at 20 minutes. And then it turns out in about 100 cases, that is the random, the individual reports that are put together. What these people have suggested is that after the activated factor VIII, in almost all of them, the blood loss had stopped. The zero blood loss somehow, I find it difficult to accept, but that's what it has been reported. We did use in one of the cases, it was helpful. So, ladies and gentlemen, to complete it, carbetocin can be tried after medical treatment while awaiting for surgery, but it has to be subject to safety clearance. External uterine pressure tamponade is an attempt when compression sutures have failed. And then maybe uterine artery ligation vaginally worth the try in the labor room. And then transvaginal uterine artery clamping, a novel method to occlude as a prelim to the other procedures if you are planning. And then suction compression of the uterus may be an option in desperation. And lastly, the surface sealants, better to seal before closuring, and reactivated the factor 7, recombinant factor 7 may prove life-saving in some situations. Then, but the trials to evaluate their effectiveness is awaited, and structured communication is very much important to be brief, accurate, and clear, and in communicating them, and probably we will save quite a bit in that. And then, of course, the triple P approach I did talk about, in that let us have triple P also include the patients, and then apply pressure, and then keep praying. And then what remains at the end of it is there anything new in the management of postpartum hemorrhage? That 15 odd extra minutes that I have taken from you is that it is only the renewed anguish and then the despair. So what it's done, it's the other day in the papers, it was all flashed around that this Chalo Rangade was the team that was going in, coloring the slum areas in Dharavi. Probably that's what we have been doing, or what I tried to do in saying that that's what is new in the management of postpartum hemorrhage. Try to tell whatever that was. It's not that any old wine in a new bottle. It is only the same wine, probably in a different bottle. Right.
Thank you, sir.